Hi, good afternoon, everyone. My name is Cynthia Klein, and I serve as the Project Director for the Take Heart Initiative. We would like to extend a warm welcome to everyone today and hope that everyone is doing well. Today, we'll be diving into the first session in our series that's directly related to care coordination, and we look forward to having a really good discussion with you today. On the next slide. So just as a reminder, today's presentation is the sixth in a series of 10 modules. All of our Take Heart training materials are guided by the roadmap that's been established by the Million Hearts Cardiac Rehabilitation Change Package. And this change package is in the Take Heart Resource Center on the website. The format of our training session is going to include a presentation by subject matter experts today on the topic of care coordination. And then we'll continue during the session with the discussion. And again, we'll be using that chat feature. We'll be using the polling features to really help engage participants and allow that peer-to-peer sharing. After today's session, you'll receive written guidance materials in the form of an implementation guide that will reinforce and supplement the material from today's session. Technical assistance will follow next week as you participate in your peer action groups with your coaches and other hospital participants. And please do always remember you can reach out to your coaches with any questions, any concerns at all during the process. So today's learning event, we'd like to hear from you. We'd like to have some good engagement, some good discussion. At the bottom of your screen, you'll see a conversation bubble that's similar to the one that's pictured here on the slide. If you click on this bubble, it'll open up the chat box. And we just ask that you please set the to field to everyone so that everybody can see your question and be part of the discussion. We do ask that you keep your questions general in nature and not hospital specific so that the entire audience can benefit. And if we are in a position where we're not able to get to all of the questions today, we will be able to respond after with responses to questions. So feel free to type any question you have within the chat box at any time. One last quick reminder before we get started, you are able to claim credits for this session, and so we'll follow up after the session with the instructions to do so. And with that, let me go ahead and introduce you to Steve Hines, who's going to take us away on this session. Hey, Steve.
Good afternoon, everyone, and we're delighted you're here to learn about care coordination and dialogue with some exceptional panelists that we'll introduce in just a second. As you can see, this is the first of 3 training modules that are focused on care coordination. Today, we'll lay the groundwork so that you understand care coordination and can figure out where your gaps and opportunities are and how you can support underserved populations. And then we'll give you a month to think through those issues while we discuss automatic referral some more in Module 7, and then we'll return to care coordination in Modules 8 and Module 9 to talk about how you implement care coordination changes, and then most importantly, how you can empower patients. You really shouldn't think of care coordination as something you do to patients or even for patients. Care coordination should be something that you do with patients, and that's the approach that I think that you'll see here today. As far as our learning objectives for today, we want you to understand why implementing effective care coordination will benefit your cardiac rehab patients. Automatic referral without care coordination will get you virtually nowhere, but you combine the two and then you can make incredible progress. Second, assessing the effectiveness of your current care coordination workflow processes for the transition between inpatient cardiac rehab and outpatient cardiac rehab, especially the transition between those two settings is critical, and our panelists are well positioned to talk about how that process should work. And then finally, understanding how to establish your priorities for enhancing care coordination. You can't do everything at once, and if you try, you'll tie yourself up in knots and you really won't make progress. So you need to figure out what your priorities are, work on those things, make progress, and then move on to other things so that you can gradually improve the processes that we're working on. Our 2 panelists today, Rachel Jarvis is an exceptional panelist for us today. We're glad she's here. She's a clinical exercise physiologist that's been working in cardiac rehab for over 20 years. She received her bachelor's degree from Central Michigan University and a master's degree from the University of Iowa. And she's currently the lead of inpatient cardiac rehabilitation at Memorial Hospital of Carbondale in Illinois, Southern Illinois. She's a member of AACVPR and their education committee, and she's the acting president of the Illinois Society for Cardiopulmonary Rehabilitation, which is a joint affiliate with AACVPR. So we're delighted that she's one of our speakers today. She's also actively involved in Million Hearts and has contributed to their change package. And then we have Tammy Garwick. She's a master's prepared exercise physiologist who also has an MBA. She's worked in the cardiac and pulmonary rehabilitation field for over 25 years, and she's held multiple positions with AACVPR and is presented at multiple annual meetings. She's also one of the authors of the CDC's Million Hearts Change Package, and so both have great insights and are eager to dialogue with you all today. So we encourage you to use the chat to submit your comments, submit your questions, make your comments, and they will be delighted to follow up with you. Now, having said that, I want to turn to our panels and specifically turn to Rachel first and ask you to tell us a little bit more about yourself and why care coordination really matters to you. And then you can turn it over to Tammy from there.
Okay, thank you, Steve, and welcome everyone. Tammy and I come from different backgrounds and different experiences, so we thought we'd kick off today's discussion by sharing a little bit of individual insights. I'm speaking to you today from the lens of what is best known as Phase 1 cardiac rehab. I began my career in a large metropolitan teaching and research hospital that didn't have a Phase 1 program. I trained and developed my Phase 1 skills as I transitioned through 2 additional hospitals. And although I've worked in cardiac rehab in all different phases, the last 10 years I have been in a small rural hospital where I have been dedicated to developing and implementing an effective inpatient program. I've learned the importance of the inpatient encounter, becoming an integral part of the hospital cardiology team, as well as remaining part of the larger cardiac rehab department and providing strong communication with the outpatient staff. We all know that cardiac rehab involves multiple key components to be successful. I want to stress the value of a dedicated cardiac rehab team member as the Phase 1 component of your coordination process. It's the trained and educated members of the cardiac rehab team that should really be implementing the Phase 1 visit. My hope is that this information provided may help you develop or improve your team. Tammy?
Thank you, Rachel, and welcome everyone. When I took over the Mount Carmel Cardiac Rehabilitation Program, we did not have care coordination between Phase 1 and Phase 2 cardiac rehab. Most of the Phase 1 was provided by bedside nurses with support from an inpatient cardiac rehab coordinator. We were relying on staff that had never walked into an outpatient cardiac rehab program to educate and influence our patients. We decided to modify Phase 1. Phase 1 started with having Phase 2 staff rotate days as that Phase 1 provider. This allowed for the patients to connect with someone that they would be working with in the outpatient program and the staff to identify barriers that the patient may experience in signing up for Phase 2. At the same time, we were implementing outpatient cardiac rehab orders as part of an inpatient procedure order set through our EMR. We were now able to identify patients that met the criteria for outpatient cardiac rehab. I would like to sit here and say that it was easy, but we had many hurdles to overcome. We tackled each hurdle individually. The staff produced great ideas along the way. In order to capture weekend PCIs, we created a video and posted it to YouTube so that the inpatient staff could still provide the education to the patients. When the personal connection was able to occur, it was amazing to see the increase in our referral process to the outpatient program. So much of this project management process coordinated with practical skills that I was learning during my MBA classes and was able to incorporate them into the process. Whoever thought going back to school would be beneficial for care coordination in a cardiac rehab program?
Excellent. So today's discussion will focus exclusively on the second element of the evidence-based Take Heart Quality Improvement Project for cardiac rehabilitation, which is care coordination. Care coordination, from my perspective, begins with the cardiac event, and then the order is entered and the phase 1 education is provided. And finally, the patients are enrolled and attend the outpatient cardiac rehab program. And we know from a prior module the value the automatic referral brings to the outpatient program. In 2011, a team of researchers led by Sherry Grace from York University in Toronto demonstrated that the automatic referral, in combination with some care coordination, improved participation in cardiac rehab to 86%. The move to making referrals automatic not only sped up the process, it allowed us to capture a much larger portion of eligible patients. However, as we all know, orders don't hold much value unless the patients understand them and see the benefit behind them. A phase 1 team member that is dedicated to this can help be the next best step in this process to improving your outpatient referrals. We recognize that patients take many roads to reach outpatient cardiac rehab, and establishing an effective care coordination team for every path is important. The focus of Take Heart is to develop the easiest path to improving the transition from the inpatient or event stage to the outpatient completion of the program. Once this team has been established, you can consider replicating, creating new, or even refining the other roads to enrollment for outpatient cardiac rehab. This slide was introduced last month, and it defines the referral based on current performance measures. As a reminder, the automatic referral alone does not constitute the referral. For a hospital to get credit for the cardiac rehab referral, the ordering clinician must have a conversation with the patient regarding that referral. Unfortunately, we all know that conversation with the ordering clinician is not always very detailed or patient-oriented, if it's had at all. They may not have the time to explain enough to overcome the barriers to participation. The phase 1 coordinator can then expand this conversation and make sure the patient understands the process. The referral is made even more complete if it's taken one step further by scheduling the patient for their first outpatient visit. The inpatient cardiac rehab care coordination team provides a system of workflow procedures and activities that move the referral from the inpatient side to the outpatient cardiac rehab side. The referral system and the phase 1 care coordination system need to work together to ensure the referral doesn't get lost and the patients make it to the outpatient program. So once you have the order, what does enrollment really mean? Well, the research tells us that enrollment is defined for cardiac rehab as participation in at least one outpatient session. However, in clinical practice, this definition isn't really sufficient for us. There are many times that patients show up, they fill out the evaluation paperwork, and then they never come back for their first cardiac rehab session. A patient's needs and concerns need to be addressed to ensure that they will enroll and adhere to the program. Adherence is key to addressing the areas of potential behavior change, as well as providing the program income to overcome all the time and resources spent in the first 5 sessions. Simply stated, what's defined as enrollment isn't really our goal. Our goal is participation to completion of the program. So why is phase 1 coordination so important? Well, getting the referral is just the first step. A trained phase 1 cardiac rehab team member can provide valuable and relatable education to the patient at a very stressful time. One useful means of accomplishing this is to rotate all your staff through phase 1 and phase 2. This way, every cardiac staff member understands and can speak to what the whole process truly entails. The interaction with the patient and their family is critical in developing a relationship of trust and knowledge that will extend to the outpatient program. If the patient and family create a bond with the phase 1 team member, they are more likely to see the value in participating in the outpatient cardiac rehab. I can't tell you how many times I've had a patient ask me if I will be with them in the outpatient program. Every time this happens, I know that I've built a bond with them and they're beginning to feel comfortable and hopefully trust the information that I'm providing. I also find value in providing them with my contact information in case they need to follow up with any questions or concerns. Referrals from many diagnoses, such as MI, PCI, CABG, and heart failure, are much higher than just 5 years ago. However, despite these improvements, we all know that outpatient cardiac rehab is still underutilized. Automatic referrals alone will not fix this problem. Care coordination needs to begin with the cardiac rehab team member having conversations with the physician to help them identify eligible patients and be able to support the physician in adapting the automatic referral. Then a detailed conversation with the patient by the phase 1 coordinator can help provide more explanation and details around the entire cardiac event and the lifestyle changes that the patient faces. This discussion lays the foundation for supporting the significance of participation in the outpatient program. This should be followed by support from the outpatient team to get the patient enrolled quickly and encourage participation to program completion. Despite the increased referrals, there are well-known disparities in participation to cardiac rehab. An effective phase 1 team member can help identify and address these disparities and help work through the patient's needs at the very early stages of the cardiac event. Many times through a conversation, I can probe out possible disparities and help develop a plan to improve participation. For example, I can work through insurance questions and concerns. If they don't have any coverage, I can contact financial assistance to help them while they're still an inpatient. I can also have a detailed conversation at the patient level about their medications and why each and every one of them is important. It's critical for the phase 1 team member to use the resources within the hospital. During the inpatient stay, we are uniquely positioned alongside caseworkers, social workers, diabetes educators, and other community resources. Please don't waste this opportunity to tap into these individuals to address disparities that may be beyond your scope of practice. We all know some of the common barriers to participation as shown here. As I stated in the last slide, the conversation the phase 1 coordinator has can lead to addressing things like how to access free transportation, or it can involve the family to help alleviate some of the possible caregiver or family obligations for the 1 to 2 hours that individual will need to attend cardiac rehab. However, it is important to point out that the lack of understanding or the belief that I don't need cardiac rehab, it's also a barrier. This is where I believe my experience working in the outpatient as well as the inpatient cardiac rehab as an exercise physiologist has given me the tools to have an honest conversation about the benefits and outcomes of cardiac rehabilitation. And I can address that I can do it on my own mentality from the patient perspective. Some patients respond to statistics and data, and other patients may need a softer, more personal approach. I also find it beneficial to use my own personal experience with exercise to be more relatable to the patients.
So Rachel, can I just jump in and ask a question before you move on?
Absolutely.
That overconfidence, when somebody is overconfident, how do you tactfully get them to the point where they recognize that, maybe they can't just switch their diet and begin exercising and do a bunch of other things that they're not doing already, without offending them or making it seem like you're talking down to them, or you don't have any confidence that they can do all the things that they think they could do?
Usually I start by validating what they're already doing and recognizing the importance of what they're doing. And then I try to backpedal a little bit and really explain what we're trying to do and what we're trying to achieve. I really speak to exercise as a medication, and it has a certain dose that we need. And cardiac rehab helps us figure out what that dose is for you. You might be right on track, you might be a little behind, you might be pushing it a little too much. And so it gives us the opportunity to not only make sure that things are safe, we're watching you, we're monitoring you for a period of time, we're keeping an eye on those rhythms. I try to remind the patient that they've had a really big cardiac event and their heart has been through a lot and they need time to just make sure that nothing else is going on. I also try to, make sure that they understand what our goal in the outpatient program is. It's not to slow them down. It's not necessarily to change their current plan. We want to push them. We want to make sure that they're doing everything that they can to reach that threshold or the dosage of exercise that's needed to slow down this heart disease process. Does that answer your question?
Yeah,
Well,
thanks
and
very
I'd like
much. Go ahead,
I'd like to
Pamela.
add to that, Rachel, to what you said is many times the most challenging patient is the one that has been going to the gym every day and they know what they do and they have a set routine. And so it's trying to convince them that you're going to provide them with additional benefits. And as Rachel said, it's validating what they're doing, but it's also reminding them that they've had some changes in their medication that could impact their exercise and the heart rate they're used to and the intensity that they're used to. And honestly, it's bringing everything else that we offer into to their knowledge. They don't know that, they could meet with a dietitian and it's part of the program, or that, their program may have a psychologist, or you have a nurse, and many people look at the exercise physiologist as personal trainers, So sometimes it's figuring out what is going to be that trigger for that patient to connect with you. And as much as we would like to say it's our skill set, sometimes it's the financial. Hey, your insurance company is paying for you to have a personal trainer and a dietitian and a psychologist. So why don't you give it a shot and let's see what we can do. So there's a lot of different ways that we can tweak it. But as Rachel mentioned, it's getting to know the patient and knowing what's working for them. Treating a 41-year-old angioplasty patient is going to be a heck of a lot different than treating an 88-year-old grandma who's never been on a piece of exercise equipment. So it's that individualization that really matters.
Which is why I like to kind of bring in my own personal, right? Like, this is what I've done with exercise. This is how I changed or progressed or before, after a surgery. So I can let them know that, hey, I'm right there with you. I exercise regularly, but this is why I still think it's important. So.
Yeah, thanks. Those are just one other follow-up on this is, sometimes you pick up on the fact that the underlying reasons why they might have had the cardiac event is just because they're depressed about life and they know what they should be doing, but they just are so depressed that they're not doing it. So do you pick up on that often? And if so, how do you handle patients where that may be an issue?
That actually just happened today, Steve. I had an individual, this is her third MI PCI, and she started the conversation very early on and just kind of briefly mentioned something about, not really doing a whole lot, just doing a lot of sitting, and then she literally threw the word depression out. And so I kind of just turned the entire conversation into validating that she is depressed, she is stressed out, this is affecting her heart disease. We can use exercise as a means to get her out, get her moving a little bit, trying to interact, and then also encouraging her in different ways to address her depression and address the fact that it's real and it is important. And so, like Tammy said, we have some of those resources. And so it actually changed my whole conversation with her today. And we didn't touch on some things that I normally would have because we went directly into that direction. So.
Thanks. That's great. And
Yep.
and I'll let you get back to
Okay.
different views of care coordination.
I like it.
Well, and Rachel, if you don't mind, I'll interject just a little there too, is that's the whole purpose of us, is Rachel had that conversation, so now she can go back and have the conversation with the PCP and say, hey, this is the conversation I had with patient Susie Smith. So do you understand her level of depression? And so she can be that resource and that conduit between the patient and the primary care or the cardiologist that helps identify and hopefully treat that depression too. So that's the role of cardiac rehab staff, is being that care coordination, exactly as we're talking about today, being that conduit between the two resources to best solve or to best work with the patients with what's identified as needs for them.
Okay. So the studies on care coordination and cardiac rehab have looked at workflow processes and activities that envelop the inpatient referral and help move it to completion. The referral system and phase one care coordination system set the tone and begin to build a relationship within cardiac rehab. The phase one visit, as well as the referral delivery, results in a positive correlation to the increased participation in the outpatient program. However, in this view, care coordination from the literature stops once that outpatient referral is achieved. It doesn't support the patient during the transition from discharge to the outpatient cardiac rehab, nor does it address the needs and the concerns of the patient, which may be impacting their participation decisions. Making sure that you have a dedicated cardiac rehab team member to provide education, question and answer, and explain the outpatient program will ensure better adherence. And to broaden that view a little bit, the literature then works with the patient for the entire duration of the cardiac care. So we need to remember that the length of stay for many cardiac events is very short these days. The phase one visit may only occur once during their entire hospital stay. It's imperative that we don't just run in and hand the patient a brochure about cardiac rehab and then tell them their appointment time. Each interaction should be tailored to the patient's needs so that with every patient, we're deliberately organizing their care activities. We're sharing information among all the participants and family members concerned with the patient's care, making sure that the patient's needs and preferences are known ahead of time, and then communicating them to the right people at the right time, just like we were talking about, whether it's this lady's depression or last week I had a lady who was waiting for her grandbaby to be born one floor below her. There's other things that they're thinking about. And we don't want to delay any resolution to concerns or barriers that the patients may have. This quality improvement project is designed to continue improving referrals, but it is also a call to action to address the inefficiencies and inequalities within your program that may be hindering patients from getting enrolled. We suggest an effective care coordination system consists of appropriate policies and procedures that ensure eligible patients get referred, enrolled, and then participate fully in the cardiac program. We will require both inpatient and outpatient cardiac rehab team members to make sure everyone is following the same protocols. Can you go back one slide? These policies may need to include inpatient hospital staff that you need to help support your outpatient cardiac rehab, and they can also be champions for your program. And I would also stress an increased focus on the patient populations we know are less likely to attend. Maybe we spend a little extra time with them on the inpatient visit to improve their participation. This project asks you to be change agents and get involved in securing the referrals, getting patients in, and helping them complete cardiac rehab by establishing or enhancing care coordination, especially in those patients in the underserved populations. Next slide. Care coordination is multifaceted. It requires communication and knowledge sharing from the inpatient side to the outpatient side. This could be the first cardiac event this person has ever had. And the discussion and education between the phase one coordinator can help set the stage for an improved prognosis. Patients can't change what they don't know. And I see this as an integral moment to explain the disease process and help empower the patient to be engaged and take an active role in their care. Again, care coordination helps the patients navigate the transitions and assesses them for their needs and concerns and facilitates their connection with community resources such as transportation, financial assistance, medication assistance, or even outpatient locations and time restrictions. Keep these elements in mind as you think about developing your own care coordination activities for cardiac rehab. So when does the coordination process take place? Well, based on the definition, an effective care coordination system should really go across and throughout the entire continuum of care, from the time of the hospital admission or the procedure to the automatic referral and phase 1 education, as well as the order from a physician's office to enrolling and completing the outpatient cardiac rehab program. It doesn't just involve one person, but rather requires the coordination of multiple individuals across the continuum of care for both the inpatient and outpatient settings. Communication is key here. If your team and your community resources are not talking or they don't work well together, the patients will suffer. We mentioned earlier the value of combining conversations with the patient and family about cardiac rehab and the automatic referral. Care coordination also involves working with the providers to understand opt-outs and ease concerns to ensure eligible patients are being referred. Screening patients for needs and concerns can help identify patients at risk for not enrolling or dropping out. Opt-out discussions are very important to have. For example, at my facility, we do a lot of staged interventions. And when we first started utilizing the automatic order set, many of the physicians didn't want to order cardiac rehab, or they wanted to opt out after the first intervention because they didn't want their patient starting cardiac rehab until after the second intervention. So I was able to have a discussion with the physicians about the importance of keeping both of those orders in the system, and that the cardiac rehab team would work to ensure that the patient did not start until after the second intervention. This is where my communication with the outpatient team is crucial. Care coordination may also include connecting patients with a former graduate as a buddy to help support them throughout the program. Keep these elements in mind as you think about developing your own care coordination activities for cardiac rehab. And please always remember that the cardiac rehab team is trained to deal with these issues. We would rather a physician order cardiac rehab on a patient without an eligible diagnosis than miss one that is. It's the role of the cardiac rehab team to dig into the order and the patient's history to attempt to determine insurance coverage. There are always options that the cardiac rehab team may be able to provide to those individuals without an eligible diagnosis for coverage. Taking a closer look at phase 1 or inpatient cardiac rehab, the focus is on education of the disease and its risk factors, as well as completing the outpatient referral. Please note that the individual providing phase 1 care needs to be adequately trained. Inpatient care and questions immediately following an event can be very different than in the outpatient setting. The patients can be overwhelmed and scared, and they're looking to you for answers. This individual needs to be a member of the larger cardiac rehab team. It can be a nurse, an EP, or an RT providing the care. It's not beneficial to have a regular case manager or general hospital staff member fill this role. It's not uncommon for me to encounter a floor nurse who doesn't know very much about the newest cardiac procedures or even the difference between systolic and diastolic heart failure. They don't have the depth of knowledge to truly sell cardiac rehab. They don't come from the foundation of literature and statistics that help convince patients of the benefits of phase 2, and they have not been in a phase 2 class to even really understand the process and the expectations.
Rachel, I get to take it over from here, and let's talk about the transition from inpatient to outpatient cardiac rehab. Patients often get lost in the transition. The focus of care coordination here is to support the patient to ensure they enroll in the outpatient cardiac rehab program. Think about what process you might implement so that you don't lose track of the phase 1 patient. It may be as simple as creating an Excel spreadsheet, utilizing the reports within the AACVPR registry, your EMR, or some other patient tracking system. There have been many presentations and webinars over the last 5 years on CU in 7. This is designed to get the patient started into the outpatient cardiac rehab program within 7 days of hospital discharge. Studies have shown that for every day after discharge, cardiac rehab programs lose 1% of eligible patients for every day after discharge. Let's not forget about the more complex patients that go to an extended care facility or use home health. It's imperative to establish a partnership so that you can get the patient started in cardiac rehab as soon as possible. We found that home health was keeping patients in their program until we contacted them and said, hey, they're eligible for phase 2 cardiac rehab. They would release them, send us notes, and we could get them started as soon as possible. You may get pushback from physicians as staff as you try to get patients in sooner. Having a open heart patient come in a CUN7 is a very different concept than most cardiothoracic surgeons are used to. Their functional capacity may be less and often require the staff to update their exercise prescriptions throughout the program. But studies have indicated you're much more likely to have the patient start and complete the program if they can, the sooner they can start. Often what a phase 1 staff member can find out about a patient is imperative to their success in the outpatient arena. Sharing this information is part of the care coordination process that impacts enrollment and graduation of a patient. As you think about your process, how are you or how do you plan to make sure that this information is shared with staff involved in the patient's care? Care coordination does not end with the enrollment of the patient. Care coordination needs to continue throughout the phase 2 process. We had a patient that shared information with our psychologist. This information became the focus of his program and required the staff to have the same common goal. The focus of care coordination is to limit barriers to patient participation and support the patient through the program to completion. So getting started with our care coordination redesign. If you've followed the course of modules, you have a firm foundation on which to build an effective care coordination system. It is essential to have a champion in the inpatient side as well as the outpatient side who can together push forward the case for effective care coordination. As you look for champions, don't hesitate to utilize your medical director or another physician champion. Physician-to-physician conversations can be very important for encouraging cardiac rehabilitation and having patients start cardiac rehabilitation sooner, the outpatient cardiac rehab sooner. As with any quality improvement project, it is important to review your aim statement and use it to help guide the decisions you make about enhancing your care coordination system. Keep checking in on your action plan at team meetings and updating as needed. Planning for redesign of care coordination requires taking a closer look at the workflow process maps created in Module 3 and data from Module 4. Establish regular intervals for evaluation with data to support the process. Data is so important, and you need to make the case with the data. Next slide, please. Thank you. Data provides objective information and can be used to make the case for redesigning care coordination. Data is a crucial part of the process change. Your data can provide you with vital information from the age disparity of your patients to most popular class time. Not only can data tell you your referral rate, but it can tell you the physician that refers to your program and the physician that does not. Now that you know the physician that does not refer to your program, it's your opportunity to market to that physician, provide education, and even sometimes invite the physician to come to your program and exercise on the equipment a time or two so they know what a patient is doing. Be transparent with your data. Let staff and administration know the data that you're analyzing. Demonstrate to the staff how important accurate data input impacts data output. Let them have some skin in the game. You also need to understand the catchment area. Understanding your eligible patient population might involve finding a friend from within the hospital and a data analytics team. I found that it took several phone calls before I could find the right person that could provide me with the data that I needed. They can pull patients within a specific time period with DRGs for the CMS acceptable diagnoses. From this initial data, they can spin it to tell you age, insurance companies, diagnoses, and zip codes. Looking at the zip codes of eligible patients provides a picture of the breadth of the catchment area. Are the patients in outlying areas being referred to other outpatient programs, or are they just not going anywhere? What type of care coordination do you have established to rural hospitals if you're a metropolitan hospital? Or if you're a rural hospital, how are you capturing patients that may have had a procedure at a metropolitan hospital? We also had multiple locations, and we're trying to figure out how we could capture patients that got lost from one zip code to another zip code. They were kind of in the in-between. So what were we doing for those patients to make it easier for them to come to a certain location? Look at the characteristics of the typical patient, then look at the characteristics, easy for me to say, I guess, of those that did not enroll or those that dropped out. You might find some common themes. Using objective data can help support the change effect. What other data do you know? Or excuse me, what other data do you need? No one knows eligible diagnosis for cardiac rehab better than the cardiac rehab staff. We can name them all off. Make sure that the patient meets the diagnosis criteria. Gather pertinent information so that you can answer patient questions, facilitate them getting in the program. As Rachel said earlier, it's important for all of your staff to understand insurance. What does Medicare cover? If you have a Medicare Advantage program, understanding what may be their copay for each session. We had a Medicare Advantage program that charged the patients $50 per session. So that was a huge barrier for us to get over, and what could we do to overcome that barrier? So we had a lot of patients who had a $50 copay per session who financials was an issue being a Medicare Advantage program. Also understand driving directions. Do you have someone who won't drive on the interstate? Do they only do rural roads? How can you give them a map to where you are? Work hours compared to program hours. Other barriers to start your for them to start your cardiac rehab program. Acknowledge individual patient participation demonstrates caring and providing a positive reinforcement. Identify what's working and what's not. It's important to regularly review your workflow process. Are you capturing all the eligible patients? For example, heart failure patients with an EF less than 35% qualify for cardiac rehab without an acute hospitalization. How are you capturing that group? Are you waiting until they come into the hospital? Do you have a relationship with a heart failure clinic? If you don't have a heart failure clinic, are you providing that information to referring physicians that that is a population that qualifies for cardiac rehab? What education do you provide to new cardiologists? Are you on the orientation process for cardiologists as they come to your institution? Workflow processes are an opportunity for continual process improvement. Create process improvement teams for various tasks. Get your staff involved, get them engaged, and they're more likely to want to continue to improve processes. Look at the wait time. How long is the typical enrollment? Are you offering class times that best fits the population that you serve? But don't forget to talk to your best resource, and that's your patients. Whether they came to your program, whether they dropped out of your program, or maybe they're a graduate of your program. And sometimes the best patients to talk to are your maintenance people, your phase 3, phase 4 patients. Sometimes they hear conversations from patients and we're the first ones to snitch on each other about what they're doing and what they're not doing, or whether they're going to quit and why they're not happy. So use your resources and talk to your patients. Identify factors that are preventing the common patient from coming to your program. So let's evaluate your process map and the data on a regular basis. Establish a scorecard so that you can track your successes versus your opportunities. When an item on your scorecard has been green for some time, see what other variable you can track with data and processes. Now it's time to look at the information you have collected. Review the data, identify trends and outliers, areas of concerns to be addressed. Eligible patients, for example, are eligible patients not starting cardiac rehab, or engaged patients not graduating from cardiac rehab? What does your data tell you, and where can you go from there? And then you need to brainstorm possible changes and track the outcomes with your change. Next slide, please. there we go. What resources that are available to you for the changes, such as the AACVP, we all know the initials, so let me spell them out again. AACVPR, value-based care change turnkeys, the change package, or utilization from your state affiliates. What can you do to decrease time from discharge to enrollment? What if you went to 2 days per week or 5 days per week of cardiac rehab rather than the traditional 3 days per week? Don't be afraid to look at every option. And oftentimes in cardiac rehab, we have a tendency to want to do the things because it's been passed down. And sometimes we just need to open our box and look around and brainstorm what other options can be done to get results that best meet the patient's needs. It's time to look at the information you've collected and make decisions about where to focus your initial improvement efforts. Use your aim statement to guide the process. Add tasks to your action plan as needed to plan for the necessary changes. In Module 8, we'll pick up with a discussion of some care coordination strategies and explain the steps to take successfully implement change.
We want to encourage you all also to ask any questions that you may have to our two panelists from today, Tammy and Rachel. Questions that you might have for them. Well, I'll put one out just because it's easy to think that their programs, you know, are so much different from yours that you really can't get to where they are. So Tammy, Rachel, in your programs, what's the last major change that you've found yourself needing to make in order to respond to a gap in your care coordination processes? And how long did it take to make that change?
Sorry, my video won't work right now. But for us here, it actually involved heart failure. It's very easy to get an automatic order set for a PCI or even an MI, but heart failure is a whole different ballgame. And so that really took a lot of one-on-one of us physically asking for orders and having to re-educate and constantly go back to the providers and let them know, hey, your patient is eligible, they are interested, can we do this? And really pushing that because we weren't getting any heart failure orders. And so we had to be, you know, the wheels to make sure that occurred.
Yeah, thanks very much. And I should add that that Take Heart is going to have an affinity group session focused on the challenges and opportunities of supporting heart failure patients. That's going to be in early November. And if that's an interest, and it certainly is of many programs, we'd invite you to participate in that. Tammy, any thoughts from your program?
Yeah, so one of the biggest things we've been working on is we were with one EMR system and transitioning to a second EMR system. So as we were going through that EMR system, it was trying to get administration to find as much importance in eligible diagnoses as we did. So that has been a huge challenge as we're living through that currently. The other thing that we did, as I'm looking through some of the chats, is wanting to bring staff and stuff over to your program. One of the best things we ever did was created a YouTube video, and you can actually search our YouTube video. It's under Mount Carmel Cardiac Rehab. And this allowed not only patients to know that they weren't walking into Arnold Schwarzenegger's gym, but it also allowed physicians to play it in their office. It allowed the dietitians, the psychologists who are not actively in our program to come see our facility, see how it works. So the cardiac rehab video, we kept it short, sweet, 2 minutes, and that really had a huge impact on taking the unknowns out of the variable so much. So those are some of the things that we really worked on the care coordination. One of the questions I'm seeing on the CU in 7 is this question on CU in 7, how did you get physician buy-in? One of the best ways for us to push that physician buy-in was the 30-day readmission rate, and how they're all very conscientious of the 30-day readmission rate. And studies have shown that the more eyes that are laid on a patient within that first 30 days, the less likely they are to be readmitted. So that's how we spun it to language that they would understand more, is that we could have an impact on the 30-day readmission rate for your MIs and your open hearts. While we can't have an impact so much on the heart failure patient, we did create an early heart failure program so that we could try to capture those heart failure patients instead of waiting the traditional 6 weeks. So talk to them about readmission rates.
Yeah, thanks very much. Those are great comments. Thanks for answering that question for us, Tammy. And we'll capture these other insights that are fabulous. I think it should be reassuring to you all to hear that other people are struggling with some of the same challenges that your program is facing, and are coming up with practical solutions which they're happy to share. So in the 2 minutes we have left, let me just remind you of some action steps that we'd encourage you to take. Continuing working with your team. You can't solve this problem by yourself, no matter how hard you work. And so working with your team to figure out your priorities, coming up with the solutions, and in the implementation guide, which we send out a day or two after each of these trainings, you will be able to see some practical suggestions or some practical tools that you can use as you start to plan your care coordination improvements. And then we encourage you to be attending your peer action group sessions, because that's a good place for you to discuss progress, discuss challenges, discuss solutions with your peers and your facilitator. So all of those things, and we want to remind you of upcoming events. Our next training module is a follow-up on automatic referral on October 28th. So you can listen to that session, take a break from your Halloween costume selection activities, and participate in that module. And then you can return to those activities or whatever else you've got on your agenda, or your kids' Halloween costumes. That may be even more traumatic for you. And then, as I mentioned earlier, there's going to be an affinity group on heart failure patients in particular. That's on November 2nd, and we'd encourage you to attend that as well. So I want to thank our panelists again, Tammy and Rachel, for some great practical insights. We really appreciate that. We appreciate the comments in the chat, and we'll follow up on those. And we want to wish you an excellent rest of your day, and also excellent progress as you continue to enhance the care coordination for all of your patients. So thank you, and have a good day.